Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting.
And I'm Catherine Cooper, Clinical Specialty Coordinator for Mothers, Babies and Women's Health at Mater.
And we're coming to you from Meanjin, the land on which this podcast is being recorded. Today we are joined by Associate Professor Sarah Janssens, Director of Obstetrics and Gynaecology at Mater Mothers Hospitals.
Sarah has been a specialist obstetrician and gynaecologist at Mater Mothers for more than 10 years and has been heavily involved in education and training, particularly simulation.
Sarah is an Associate Professor at the University of Queensland, and she recently received her PhD in Teamwork and Leadership in Maternity Teams.
But today, she's joining us to talk about progesterone's role in preventing preterm births.
Mater.
Caring for the community for more than a century.
Innovators in health, education and research.
Home to world-class clinicians.
State-of-the-art facilities.
High-quality, patient-centered
Australia's largest and leading
Turning
maternity
scientific
provider.
discoveries
Educating the
into
nurses
life-changing
in
outcomes.
healthcare advancement
Compassion and integrity.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Back to basics, what is progesterone and what role does it play?
Well, progesterone is a hormone that the female reproductive tract creates. It's usually made in our ovaries when we ovulate, but it's got a really important role in maintenance of a pregnancy. And how we know this is that initially when we get pregnant, our corpus luteum, or the little area from which the egg has been released, produces the progesterone. And then after about 7 to 9 weeks, the placenta takes over production of that. And in that critical time, if you take the corpus luteum away, we know that the pregnancy will fail. So it's really important for pregnancy maintenance. And what we also know about progesterone is that it helps to keep the uterus quiet throughout the pregnancy. And the very high levels of progesterone that we see in pregnant women's bodies fall precipitously as labour starts. So that's how we know that's got a really important role in the initiation of labour.
So I was going to ask about, what made us think to use progesterone in prevention of preterm birth. You've kind of answered that a little bit. Is that just a linear progression that we thought this has a role, so we'll use it to prevent labour happening?
Yeah, I guess there's been a lot more science behind it, I hope, and studies on what exactly that role of progesterone is. So it's a really interesting hormone because it actually has multiple effects. So within the uterus itself, it helps to prevent the formation of what we call gap junctions. And so they're the connections between the myometrial cells, which help to propagate contractions in a coordinated fashion. So it stops them sort of being formed. It also has some pretty important immune modulation type effects that probably prevent initiation of inflammatory pathways, which again can initiate labour. So it probably acts on multiple levels to prevent, labour starting early.
How does it work once it's in the patient's system?
Well, that's a very interesting question because, in fact, we would think that it works by increasing our natural levels of progesterone hormone. But in fact, later in pregnancy, our own hormone levels of progesterone are actually really, really high. And so it is questioned how, I guess, the addition of progesterone to our already naturally high levels, which are probably saturating our receptors, actually works. So there are some theories that perhaps it might work more locally within the vagina and be altering the vaginal microbiome or the inflammation or actions directly within the cervix. That might be what its main mechanism of action is. So there's a lot we still don't know about it.
So, Sarah, we use progesterone for treatment of other things like breast cancer and endometriosis, even birth control. Does that work on the body in the same way?
You're talking about maybe two different chemicals. One is natural progesterones, and the stuff that we take to treat endometriosis or what's in the contraceptive pill are a more synthetic form of progesterone, and they're called progestogens. So they act in a different way and probably don't have any actual mechanism with respect to preterm birth prevention.
If someone had been taking progesterone prior to conception, would that have a residual effect?
Not really, we don't think, because we think that the half-life and the bioavailability is actually quite short, which is why we tend to use daily dosing. Yeah.
In Australia, progesterone has approval from both the Therapeutic Goods Administration and Pharmaceutical Benefits Scheme for prevention of preterm birth in singleton pregnancies where there is a short cervix or a history of spontaneous preterm birth. A streamlined authority is available for a daily 200 milligram pessary and must be commenced no earlier than 16 weeks gestation.
Sarah, what types of progesterone are there?
Yeah. So you can take progesterone in a number of ways. So you can take it orally, although that's not used in Australia for this purpose. And there were actually lots of studies in America where they used an injectable form of progesterone, so intramuscular daily injections. Unfortunately, the studies have shown that that actually is not as effective, and that was never actually available in Australia anyway, but it's actually been withdrawn from use for that purpose in America due to its lack of efficacy. So vaginal progesterone is now what is used here in Australia and is what is most effective.
So what would a typical progesterone regime look like for the prevention of preterm birth?
So typically would be starting around 16 weeks gestation or later if the diagnosis of a short cervix occurred later. And generally continue up until about 34 or 36 weeks, most of the studies have shown. And usually just a nightly vaginal pessary of 200 milligrams.
So stopping at 34, 36 weeks, why that point?
Yeah, I guess at that stage, the risk of delivery at that gestation is much less for the mother. And I guess that's what the studies or for the mother and the baby, and that's what the studies have generally used. So that's a funny thing about research, isn't it? Like this is how the protocol was in the research protocol, so we would use it up until then, yeah. And I guess your progesterone levels are going to be really high at that stage anyway, so.
So Sarah, if a woman has been identified as having a need for progesterone, where did she get it? Who prescribes it?
Well, recently it's been listed on the PBS for women with both a indication as a history of preterm birth or asymptomatic short cervix. So a GP can prescribe this. A woman doesn't have to come into hospital if a short cervix has been identified or she has that risk factor. So I think it's important because we believe that early initiation is probably going to be most beneficial. So whoever sees the woman first can prescribe the progesterone. But of course, if she's identified at high risk, then by a GP, she needs to be referred in for review at a hospital.
So what's the efficacy of progesterone in preventing or delaying preterm birth?
Yeah, it's quite effective, but it's not 100% effective, of course. And there's lots of different causes for preterm birth. So we don't understand all of the mechanisms. So progesterone is probably just one thing that's affecting one of those pathways that leads to preterm birth. But the studies have shown about a risk reduction of 0.6 consistently. So for preterm birth, say less than 33 weeks, we're talking about a difference between, and this is in women with a known short cervix, so we know that they're at high risk. So reducing that preterm birth before 33 weeks from about 22.5% down to 14.5%. So it's pretty effective. And then the consequent, I guess, complications for the babies being preterm are all of similar magnitude and reduction. So low birth weight, respiratory distress, needing to be in the NICU, they all come down, I guess, in concert with that reduction in the rate of early delivery.
The meta-analysis from the same randomised trials demonstrated that in preterm births less than 28 weeks, the risk was reduced from 11% to 8%.
Looking at the patients, who would benefit from progesterone and who wouldn't?
Yeah, that's a great question. And I think we're still finding our way with that to a certain extent. The indication for it is women with an asymptomatic short cervix. So that this is women who are not experiencing symptoms of preterm birth like contractions, or they've broken their waters to get already, or they're bleeding, and that's the indication. So with the asymptomatic short cervix, and that's less than 25 millimetres on a transvaginal scan. I'm sure someone's already gone through that, so I won't go over that again. So that's the group that definitely has benefit. The other indication, and listed on the PBS for progesterone, is women with a history of preterm birth. But the benefit in that group of women is actually a little bit more controversial. And a recent meta-analysis demonstrated no benefit for women without a short cervix, I guess, at diagnosis and only a history of preterm birth. But it gets a little bit murky. So, certainly we would advocate that if you've got a history of preterm birth, that maybe you should have cyclage or you could have progesterone. But certainly monitoring the cervical length is really important because we know that's the group of women who are going to benefit from progesterone. Having said that, not everyone has access to regular cervical length monitoring in rural or regional areas, or women are socially disadvantaged, for example. So we certainly don't think that it would be wrong to put women on progesterone simply because they had a history of preterm birth, but we would certainly advocate for serial cervical length monitoring because progesterone will only help up to a certain point. And when your cervix then is shortening despite progesterone, like it's getting less and less, and say it's less than 10 millimetres now, that's a group of women you don't want to miss because they may benefit from a cyclage at that point.
Are there any risk factors that would rule someone out completely?
There's no absolute contraindications, I would say, to it. Certainly we don't tend to give it in women who have already ruptured their membranes or are in active labour or showing signs and symptoms of preterm labour, because I think however it's working, you've probably missed the boat once women get to that point.
How would the administration of progesterone change if we were talking twins or higher order multiples?
Yeah. Well, as you know, they're at much higher risk of having a preterm delivery. The data on twins is actually much the same, but much smaller numbers. So there have been some meta-analyses that have looked at all the randomised controlled trials and then pulled out those small numbers of women with multiples to look at that. And there does seem to be an effect. Some centres tend to use a different cutoff, like a 20 millimetre cervix. We tend not to use that here. We still tend to go with the 25. But I think certainly with twins, you're just on high alert anyway, but we don't think, again, that progesterone is going to be harmful, but they've got such a high rate of preterm birth already. You imagine if your baseline risk is much higher, you might still get a relative risk reduction of 0.6, but you'll still have an overall high rate of preterm birth even if you use progesterone.
What about, talking of risk, what about any short or long-term effects for the mother?
Yeah. Well, it's kind of annoying having to put a vaginal pessary in every night would be the one thing, but the things that women mostly report are just irritation of the vagina, and certainly they get vaginal discharge from using the pessaries. That would be the most commonly reported side effects.
So an irritation. Yeah. What about the infant? Any side effects for them?
I guess we know that because of the reduction in the risk of preterm delivery, that the short-term outcomes for the babies are much better. The longer-term studies are smaller because we haven't really done a lot yet, but there was some look at some studies, again, a meta-analysis that looked at outcomes from 6 months through to 8 years. And there was no detected difference in neurodevelopmental outcomes, but there's a lot of outcomes that have not been looked at, and we certainly haven't seen yet the results of these studies going on into adolescence or adulthood. So there's a few unknowns there for sure.
So would that be something that we would want to consider looking into the future of using progesterone?
I mean, I think always safety is always at the back of our mind whenever we're using a new therapy. I think natural progesterone, we've got no reason to believe that it would be unsafe, but you never know. And so we must continue to do those long-term follow-up studies and check that there's no increase in risk of, cancers in people who are born to mothers who had progesterone when they were pregnant, or any other problems like reproductive tract abnormalities or fertility issues, for example. We don't think there will be, but that's what we need to be doing in the longer term.
Absolutely. Well, Sarah, thank you so much for joining us on sMater.
Thank you. Thank you. Before we go, we'd like to introduce you to a little segment we call the checkup.
So this is about the medical professional, but also Sarah, the human, the person. We've got 5 quick questions.
I'll do my best.
Deep breath. You ready to go?
Yep.
Okay. What TV show best portrays your profession?
Oh, goodness. Can I say in my younger years, Scrubs?
Fantastic. How would you describe your handwriting?
How would you describe my handwriting?
Well, I'll say no more. I chose that question especially for you.
Barely legible,
I'm thinking that's not great.
Barely legible. What's on your surgery playlist?
Ooh, it's funny. I don't tend to listen to music too much when I'm operating, but I don't mind if other people listen to music. I have this terrible verbal tick that I do lots of ums. And so whatever the registrars feel would drown out my ums. That freaks them out a little bit when we're operating together.
Who do you admire?
Oh gosh, I admire everyone in our profession who really dedicates their lives to what we do and makes working with all my friends enjoyable.
And final question, if you had a day off today, what would you be doing?
Cleaning and organising.
No, that doesn't sound fun at all, Sarah. Well, thank you so much for that, Sarah. Thanks for joining us on sMater.
Thank you for having me.
And also to those who've tuned in from home or the hospital.
Please join us for our next episode where we talk about cervical cerclages with Dr. Adam Bush.
See you next time on sMater.